identify that.
And while you're doing that, Jen, Laura, I see that you're having some trouble with your audio and video. So no worries, just kind of see if
I think I fixed it.
Yay, fantastic.
All right, we are live, and I am also going to hit record on my end. All right, we are ready to start.
Great. My memory is, Josh, that we are going to do introductions and call to order. And I know, Jen, you've just been solving a lot of problems. Did you want me to jump in and do the intro kind of handoff to Josh?
Sure, that would be great, Rachel.
Great. Well, greetings everyone who is on the live streaming and also in our Zoom room and in the on-site room as well. My name is Rachel Freeman. I'm from the University of Minnesota. I'm the facilitator or one of the facilitators of this group, but we also have two co-chairs. Know that as you proceed through the meeting that the live streaming is recorded. We do have an email address that you can use to give us feedback from the live streaming. So that is kind of the general introduction and the comments for open for moving forward. I am going to hand it over to Josh to call to order, and Jen is going to be recording people who are here in the council to make sure that we have that quorum.
Thank you, Rachel, and welcome everybody. So I will call the meeting to order at 12:36 p.m. and turn it over to Jennifer. So a little bit differently than last time, Jennifer's going to do a roll call and just call everybody's name, and then we can acknowledge whether we're present or not, I suppose. So I'll turn it over to you, Jennifer.
Perfect. Thank you. All right. So I am going to do a roll call. I'm going to go based on our list of council members, if you don't mind. I am going to ask Tom Delaney in attendance. I see your.
Hi, sorry, this is Rachel Winarka. Tom's my supervisor. I'm here until he can get here.
All right. And do I see Carol Backstrom?
Carol let us know that she has to be up at the legislature today, so she will join when she can, but she's not here right now.
All right, Natasha Murr?
Yep, Natasha Murr is here. Hi, everyone.
Brad, perfect. Brad Johnson?
Brad Johnson's here.
And Susan Pleasant?
Present.
And Cindy St. George?
I'm here.
Jessica?
Here.
All right. And Simone Warren?
I am here. Simon Warren.
Simon, sorry.
Yeah.
And Kathy Shavers? And Jody Donne? How do I pronounce your last name?
It's Donne. I'm here.
Thank you. All right. And Mary. Mary. All right. And Janelle?
I'm here.
Thank you. And Randy Baumgart?
Yep, I'm here.
All right. And Tim Mitteldorf? And I see Sheila entering right now. I'll go back. Josh?
I am here still.
And Nicole Buchek?
Present.
Thank you. And Laura Arnold?
Here.
And Sheila Grissom?
I'm here. Thank you.
Okay, perfect. All right, so let me move things around. And we have 13 people in attendance, and so the quorum has been met.
Awesome. Thank you, Jennifer. And then the next thing we have is to approve the agenda. So this was sent out in an email attachment a few days ago. Hopefully everybody had a chance to take a peek at it. If there are any questions or concerns or additions, otherwise I would take a motion to approve the agenda.
So moved from Brad Johnson.
Is there a second?
I'll second from Laura.
So we have a motion by Brad, a second by Laura. Any further discussion? Hearing none. All those in favor, please say aye. Aye.
Aye.
Aye.
Aye.
Opposed? Perfect. All right, we have an agenda. So then we will move on. The next thing on the agenda was to review the meeting minutes, or to approve the meeting minutes from the last meeting on January 25th. These two are included in the packets or the information sent out. They're also posted. They're not posted online yet until we approve them. But if folks had a chance to review, and if there aren't any questions or corrections, I would take a motion to approve those.
This is Sheila.
Motion by Sheila. Is there a second?
I'll second. It's Laura.
And a second by Laura. All right. Any further discussion? Hearing none. All those in favor, please say aye.
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 Opposed? And we have approved meeting minutes. All right. Now we are, gosh, thoroughly ahead of schedule, and moving on to the next thing on the agenda, which would be talking about the report. Rachel, if you're on deck, you're on mute.
Thank
we
you.
go.
Sorry, I was muted. So I was just saying that in the last meeting, there was a request that we start our outline for a report. As a reminder, this council is meant to come out of the year's process with a report with recommendations for how to address barriers to acute care transition. So I am going to take you through some first steps and then show you an outline. It's really it's good that we have this extra time, because I think there's some kind of thorny discussions, some complex discussions that we want to talk through. And Jen, I'm going to share my screen if that's okay. All right, just bear with me here. I'm just going to pull up the document that you all have, and I'm going to drop down to page, I believe it's let's see here. It is on page 9 of the document that you all received, and it's called Preparing for the Acute Care Transition Advisory Council. And it's dated January 31st. Really, that's because I was working on it at that time. But we wanted to start with a conversation about the kind of clarifying, what are we talking about when we talk about acute care settings? What are we talking about with respect to our target population? And so the document I sent you is meant to kind of start that ball rolling, which is that the council's main goal is to address barriers to transitions from hospital emergency room settings into the community. We wanted to call your attention to the fact that there is defined in statute acute care facility, which is a bit broader in its definition, but that is kind of where we're at to just confirm as a council that from the point of view of this council, our report is going to focus on this particular area of barriers to transition from hospital emergency room settings into the community. I want to open that for any questions or comments at this point. There is a hand up.
Yeah.
Question, is this hospital, emergency settings into the community or only emergency room? Because one of the areas that I think I'm representing is discharge from the hospital who've already been admitted. So just looking for clarity on that. We tend to admit people instead of leaving them in the emergency room. Let's just say that.
Yes, yeah. Natasha, did you want to jump in and comment? I know we've had some conversations about really being clear about our focus point.
Yeah, I mean, from my perspective, I think it's both, right? It's folks that are stuck in the ED and not admitted, as well as people that have been admitted for whatever reason, treated, and now are there without a need to be at a hospital level of care.
So really both.
Correct. Yep, that's my view.
Right. So after that, the next target sort of goal for us, and unless there's any other comments, sometimes if anybody, Brad or Laura, you can see people wanting to talk. I can't.
Well, Rachel, this is Josh. I would just say something too. I mean, I think that makes sense as far as what we're looking at as far as the acute care setting itself. I think, for my brain and hopefully for others, I think some of those solutions though, or potential recommendations may involve all pieces of the healthcare continuum that may need, some focus or attention or some solutions that we'd be looking at. So, I mean, I think it's helpful to kind of clarify that that's the population of folks we're looking to really help solve the issue of being stuck. But then it's, all along the healthcare continuum, those recommendations may play into that. So I just wanted to throw that out there and correct me, Natasha, Rachel, and others if I'm wrong in that as well.
Yeah, that's my understanding. I think that we're moving into that target population conversation, Josh. I think the starting question that I was wanting to make sure that we, had anchored was the setting itself. So that was important. And Laura, I see you've got your hand up.
Yeah, one, I agree with Josh, but two, I think, right, we're starting at that target population, but we need to focus on those other settings because that's what's creating the backlog, correct?
Yeah, I mean, I think the idea is to make sure that we're just clear that we're moving forward with that as the major thing, not that we wouldn't address other issues or other settings. It's just that to be clear as we write the report and we focus on the information and data collection and all that kind of stuff, we want to be, making sure that we address the main goal. So I do think everybody's comments are perfectly on point. Okay, Randy.
Did you say us? Sorry, I don't know.
Yeah, sorry, Randy, I saw your hand up. Yeah.
We kind of just have a question of kind of about, now I'm kind of losing my train of thought. So is the sole purpose to get people out? Have we talked to people in hospital setting? Is it the main issue of people discharging the ones that are coming in for that really short kind of period? Or is it, I'm just curious on where the kind of the purpose of this meeting is to help people get out of like hospitals and other facilities, acute care settings. And I'm just curious where the decision was to just make it about hospitals like emergency department and maybe a short term or where I'm just curious on where that came from of trying to figure out where the issues are. Because I just personally work with or from Randy's experience, his doesn't really apply to that. He's been more one of those that's been one of those who's had extended hospital stays because there's no place for him to discharge to based on his conditions. And so I'm just kind of wondering where that decision was made and how that decision was made is kind of where I would like clarification if possible.
So sorry, I'm trying to figure out how to raise my hand online so we can go in order, but I couldn't see it. So I think the first thing we need to think about is going back to the statutory mandate that this group has in terms of, that's what we're obligated to characterize and produce. That's what the legislator directed us to do. So it might be helpful to pull that up for us to look at, because I think that has to guide how we're structuring the report, right? Because our fundamental job is to create a report that's responsive to the legislative mandate. Having said that, I think it would be remiss of this group not to talk about the whole continuum of healthcare, and in the body of the report, identify that, you know, people stuck in hospitals or acute care settings are symptomatic of other kinds of system blockages, right? And we do have to look across the healthcare continuum. I mean, I'm not saying that exactly will be our recommendation, but something like that to me would make sense in terms of kind of, I think we're going to have to be really judicious about how big the scope of this report is, because sometimes this issue is so multifaceted that it gets really hard to narrow down kind of what we're doing. And then all of a sudden we're talking about every system problem that there is, and then it's hard to get to a recommendation that will address the specific issue. So I would just offer that as I think we do have to take some of the guidance in terms of the scope of the report from the legislature, not because the other issues aren't important, but simply because like that's our job one, is to get to that report.
I appreciate that, Natasha, and I think that's my biggest concern right now as we start talking about the target population, because it really does broaden the scope of what we need to be looking at. And so I see that people are looking for the legislation, so we'll make sure that you have that. It sounds like the collective understanding is that we've got this legislative kind of goal within the council, but we also know there are these secondary and other types of issues that we need to address. But the big issue, I think, is right underneath the acute care setting definition, which is the target population. So we started out with a really simple sort of list of, you know, issues related to barriers, may include physical disabilities or challenges, health, mental wellness, substance abuse issues, challenging behaviors, failure of systems to address the unique needs of children and adults. But then what that does is it leads us to quite a large population of people. So you've got autistic children and adults who may be engaging in challenges that our services are trying to figure out how to support effectively. We've got individuals with intellectual and developmental disabilities, children with mental health diagnoses, and related psychiatric sort of episodes that may be occurring, children, youth, adults incarcerated or placed in psychiatric residential treatment facilities or alternative sort of settings. So this is where some of the conversation I think has been coming up. Individuals with health and wellness challenges or physical disabilities, older adults with dementia, Alzheimer's, et cetera, and then children or adults who are experiencing substance abuse issues. And I do see that, Brad, your hand is up. Let me just, the last one is children or adults who enter acute care for health-related reasons, but are unable to transition because of issues that have to do with systems. So those are the things that people have come up with to get ready for this conversation. Brad, go ahead and share your thoughts.
So I think right now we're just talking about the target populations that we're looking at and how do we define that. And in response to Randy's concern, that final bullet point, Rachel, which you just read, I think squarely addresses Randy's situation, because it's children or adults who enter acute care for health-related reasons, but are then unable to transition home because of issues. And I don't know if home is the right word there, or if it's they're unable to transition to the next best place or whatever. But I think if we can all agree that these bullet points capture the people, or can allow us to have a discussion about the people that we're trying to assist through recommendations to the legislature, I can certainly get behind it, because it includes, I think bullet point 4 is children, youth, or adults, I might say, and adults incarcerated or placed in psychiatric residential treatment facilities, alternative education settings, out-of-home placements, etc. I might even put in there, or recommend that we put in there, jail. But the incarcerated part is the critical focus there. So I mean, I would just say I can get behind this. Thank you.
Jessica?
Yeah, I really appreciate you taking the step to doing this, because I do think it's a key thing for us to figure out here. And while I want things to be obviously inclusive of anyone in this situation. I think in terms of shifting our heads into, okay, we have to produce this report and then recommendations to go along with it, it would be helpful to understand a little bit about like the scope of, is it more, are some of these populations more likely to end up in this situation? Are there much higher number or longer stays for certain subpopulations here? Because not at the exclusion of other populations, but I think that will help us kind of allocate our focus a little bit on, you know, on that. So I don't know if that's possible, but I do think it would help me fully get behind, okay, I think we've wrapped our head around who it is we're kind of talking about coming up with recommendations for, or at least stepping in that direction.
Thanks, Jessica. Cindy.
I would just agree and say, I think same point. I want to be inclusive, but I feel like we do need to be really mindful of scope, because I think, and maybe we just need a cleaner definition of when we talk about acute care, because is it all of these populations that are, receive acute care? But this doesn't seem clear to me in defining the scope. And I want to be inclusive, but then are we talking about if we talk about people who are incarcerated, and then is that just, I guess I'm not sure how those patient populations fit within our scope. Because it feels really huge.
It is really.
Or is it just naming the people that are, is it just naming people who are, I come from the hospital side. So is it just naming all the people that we treat within our system?
I think what I'm seeing is people who are experiencing barriers to transition back into the community setting in whatever setting that they're in. And that is the issue, I think, Cindy, that we're all kind of looking at here, which is this is a really big scope. It is bound right now to that first section, which is it's not every single population of persons that we're talking about. It's the people that are going into the emergency room, getting stuck and not able to transition back home, and we're struggling to figure out how to help support and provide recommendations around those issues. So I do think you're right that it is a very large kind of task for this council.
So our ask is and scope is patients in the hospital and in emergency rooms.
People who are in emergency rooms who are having trouble getting supports and transitioning back into the community. I think that's the part. And Jessica's point earlier was, it might be helpful if we could use data or other types of things that would help us look at where the burning problems are, because this is a very large kind of group of people that we're talking about. Laura, your hand is up. I don't know if it was up before Nicole, so I'm going to go ahead and let you talk, and then Nicole, if that's okay.
Yeah, so I was trying to phrase it before too. But I think though the incarceration / like extreme behavior needs subset is a big factor, even though it doesn't seem as though, because they tend to have a lot of high mental health needs. And if one of our target populations are mental health needs, like they take up the same beds that we're trying to get people out of the emergency room and onto next settings. So like, it's hard to parse that and say that's not part of our scope, if that makes sense.
Yeah. Nicole.
Yeah, the only other thing is, if we are being inclusive with the definitions here, the only component that I'm not seeing listed is the barrier due to individuals who financial situation doesn't allow for transition. So individuals without insurance, or individuals who may be experiencing homelessness, and that programs around them based on, their location, don't accept certain funding sources. And so that being potentially something that is missing from the list.
That's great. Thanks. I'm going to add that in. I think it can be included in the systems kind of issues, but I think clarifying it would be helpful. And that's something that was mentioned, I think, in that second meeting. Randy, what do you want to say?
So we were talking, and part of it I think might be able to kind of, there's been a lot of discussion on how the population and trying to narrow that down. If the focus is going to be on hospital and getting people out of that, I really think that probably trying to determine the population that really kind of focus is speaking with the hospital social workers and things like that and they might have the good insight of who gets stuck, what population is the one, instead of trying of us kind of determine. I think going to the source of those hospital social workers who are the ones who are doing the discharging planning along with the nurses and the nurse practitioners and the doctors and all of that. I think that would be a really great piece of trying to figure out what population would be best served, is going to the people who are doing this directly and what issues are they running into, because that's where, and one last point is oftentimes if they get out of the emergency room, a lot of times what happens is they just jump to the nursing facilities that are not able to meet their needs. Randy was in a nursing facility. They got him out of the hospital, but he was in a place that provided him with not great care. And then he ended up back in the hospital. And so sometimes I think we need to look at, which I know this is such a broad and really big issue, but sometimes the solution of just getting them out of the hospital, sometimes I've been in a lot of discharge planning where hospitals will push people into homes that are not appropriate. There was a time where Randy was in the hospital and they wanted him to go to Brooklyn Park to a home that wasn't accessible, and he would have got in the door and he would have stayed in that room, and that they thought that was an appropriate plan. And that was not appropriate. That's not giving him a quality of life. So that sometimes I just have to say that sometimes even just getting them out of the hospital doesn't solve the overall problem.
Yeah, I think that's a really good point. Susan.
Yeah, I was just going to respond to that. The reason this task force was created is because there is information and there is data that shows how many people and in what barriers, and we should get that. And I have it. If we haven't already gotten it, I can get it through the MHA, which is what I'm here representing, as well as through the legislation. And we talked about this last time. So I think we have the scope if we just look at the data we already have. We've talked to those people, the social workers, for instance, at the organization I work for, Fairview, report to me, and I believe we have another representative over that area on this committee. So I think we know. I think we've got a pretty good understanding of what these issues are. This is a broad scope. I think we have volumes that could potentially help us prioritize. And I think we should, after this, try to start honing in on how we create solutions, because we wouldn't be here if the issue wasn't already defined. And maybe we haven't done a good enough job yet here today at making sure everybody understands the data and knows that information. But
I think that's a key point, Susan. The council does not have this data that you're talking about. So we need the data to be able to have an informed report and process. So anything we can do to get those data and have it here in a way that it can be digested would be really helpful because you're saying it's available.
We talked about it last time, and I thought somebody was going to be able to get that because we submitted it to the state. All the health systems in the state did. So, and I put in the chat, and I'll do it again. Please reach out to me if somebody else is unable to get that. I'm confident I can work my way into getting that data for us.
I mean, I think the key thing is having an action that somebody reach out to you to get those data. So that could be something that we write down as a council. I think that always the problem is making sure that there is a dedicated person whose job is to kind of do that reaching out. So does the council, chairs or anybody else have some suggestions for an action that we could move forward with to get those data? I mean, it could be as simple as saying, ask Rachel, the facilitators, to see if we can kind of reach out to Susan. So, it can be as simple as that.
I would like to ask that Rachel or one of the facilitators reach out to Susan and get that data and maybe simplify it into a visually understandable format.
Great, thank you, Laura. And it's
this is Brad. It sounds like Laura made a motion, so I'll second it.
Well, I wasn't sure if it was a motion. Is it a motion or an action? If it's an action, we don't need to vote on it, but if you
Alright.
feel like it needs to be a,
I think it should be an action, don't you guys?
It's an action that I'll support, I can tell you that.
I'll support it too. I'm happy to make it, if we want to make it a formal motion, I think we should, because I think we do want to move this forward.
Okay, so Laura made the motion and I'm assuming, are you going to make that as a second?
Yeah.
Okay, or Brad.
I'm going to interject for a second. Sorry for the motion, teaming up. I just want to make sure we have the language right. That Laura, you're asking Rachel or one of the facilitators to reach out to Susan Pleasance and secure data, and then transfer the data into a usable format. Is that, or what was your wording on that?
Or usable format would work, or a visually understandable if we're going to be presenting it within the meeting.
All right.
That's great.
Yep.
So Jen, do you have what you need? We, just so you know, we had a chair meeting to talk about slowing down when we get to the motion part, so we make sure we get it right. So I appreciate Jen, you jumping in at this point. Do you want to read it back to us, Jen, so everybody knows what the motion is?
Yeah, the motion from Laura Arnold, right? The motion is to ask that Rachel or one of the facilitators reach out to Susan Pleasance and secure data and transfer data into a visually understandable format. I'm going to post that in chat as well.
And I just want to ask Cindy, are you wanting to comment on this motion, or you got something that's coming and we want to circle back to?
I'm in support of the motion. I just was gonna comment, but just to say for clarity too, that I represent hospital and hospital social workers, so who are doing this discharge work. So I just agree that there is data out there. There's data that we provide. And so I think we're moving in a good direction, because I think that will be important to help us define our scope and narrow our scope.
Yeah, Cindy, let's circle back to that a little bit and dig a little deeper after this, but let's go ahead and have Josh. Is Josh here, or did he have to leave?
No, I'm back. Sorry.
Okay. Josh, we are at a point where a motion's been made and seconded. We've started some discussion. I see a hand up. Should we keep going with that?
It might be related to that motion, but it might be a second one down the road. I know I had found, and I'm sure other people saw it, like, again, just there was like a recent article, it was specific to children, but getting stuck in hospital settings, from Sahan Journal, and they had a lot of the kind of high level summary data. I wonder if we could also try to figure out if we could get those same data to inform this report, or at least, augment it the best we can with what's available. I don't know if anyone had thoughts on that, or if you saw that same article come out.
Jessica, are you asking for amendment to the motion, or do you want to make a second motion after?
Well, I guess I'd like to clarify, if it's okay, if the data we're asking for from Susan would have that level of information, and then if it doesn't, we could go ahead and move forward on that motion, and then maybe talk about another data source we would need.
I can just speak to the data that I know I have, or I can get through the MHA. It's just all individuals who stayed beyond medical necessity, either in the ER or in the hospital. And then there's a categorization of types of barriers that we submitted to the state for some legislation, which I think was one of the reasons we exist. And then we did a second data capture. So I don't know that it would include that.
Okay, maybe we could, Rachel, if you want, or whoever, we could move forward with that motion. I'll try to find that article again and link it in the chat, and maybe we could talk about that one later or after.
Okay.
All right, so to reiterate, for my brain's sake, we have a motion by Laura to ask that Rachel, one of the facilitators, reach out to Susan and secure the data that was just talked about, and transfer that data into a visually understandable format. I don't see in that little chat box who seconded that, so.
That was Brad.
Oh, Brad or Jessica, yeah.
Awesome. Any further discussion on that motion as it's laid out in the chat? Hearing none, all those in favor, please say aye.
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 Is this one we want a roll call for? Because I know that Jen's gonna have to document,
I can document it based on who's in here, Rachel. If you don't,
we can do a group vote, do you think, Josh? And then,
I
if
think
there's
it's
nobody,
perfectly fine, and if we were to, you know,
if
if
there,
somebody calls for a roll call, we can do that. But so I'm going to finish this. So anybody opposed? All right, that motion passes, carries, whatever the right word is, and we'll move forward with that.
so this is a point, Jessica, where the question is, do you have another motion in mind?
I don't, I guess, at this point, but I do wonder if we're trying to look for data sources. This article lists hospital level data from 2023 of number of children boarded. And there were the longest length of stay or their average, the longest stay in days. And I'm just wondering if we'd have those data elsewhere or data like that for some of these other populations that we're talking about.
Yeah, and I actually found, I've been doing some literature review stuff, and so there are a few other reports hanging out there, not very many, but I think your point, Jessica, is kind of making sure that we've got all the data that we can find. Is that kind of, you know, so it may be, a motion might be around a literature review or a sort of formal seeking of data. I know we tried to do that informally in the council meeting, and we haven't quite gotten there yet.
Yeah, maybe it would be an action item, maybe because it's not firmed up enough to know what the motion would really be. But I guess I would ask for an action item that facilitators could try to locate other data sources about the populations that we're currently defining, and what their experience looks like from the most recent data sources we could get.
Thanks. Brad, thoughts?
Yeah, I just wanted to kind of throw 2 cents in and say, when we're looking for data, my preference would be that we're looking for original source data as best as we can, as opposed to anecdotal, editorial kind of data or articles on one side of an issue or another side of an issue, even though some of those articles oftentimes have, you know, the data built into them where you can hyperlink to where they got their source data. But to the extent best as possible, I'd like to look for the best evidence and the original source data. And if we get things like, this is an interesting article from Sahan Journal, but if we can trace it back to the root and then get the original data, that would be my preference.
And just noting, Brad, that was what I was asking for. I was maybe
Yeah.
in a roundabout way, but that I
Sure.
agree, and that's what I was also asking for.
So
Thank
Jen,
you.
at this point, we need to document the action. Do you feel like you've got that written?
I have that facilitators will review literature and other data sources to identify original source data.
Great. That sounds good, right, Brad? Sounds like what you're.
And I was just going to say, I'm guessing, Jessica, you would make the motion on that one?
I can, yes, if we want to make that a formal motion.
Do you feel that, because Jessica at first said that might just be an action, so I'm asked, I think it's up to you all what you want to do.
I mean, it sounds similar to me in my brain to the last one. We might as well just do it that way. So
yeah, okay. I will make that a formal motion.
I'll second.
So we have a motion by Jessica, a second by Laura. It's in the chat. Any further discussion? All right, hearing none. All those in favor, please say aye.
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 Opposed? Motion passes. All right, so we got some action items.
Okay, great.
Rachel, I'm going to pause for a second. There are a few comments and quite a few comments in chat here that or we should probably read for the purpose of making sure that everybody who is live streaming or open on can see what has been discussed here. All right. There were comments about in the beginning of the chat about streaming if we had our audio and streaming on. So I'll let you know about those. As Cindy mentioned, should we say from hospital and emergency room settings? So that linked to the conversation earlier about settings. Susan indicated yes. Sheila suggested, I think, that we'll end up reviewing and making solution-focused recommendations that will include other healthcare and community settings, as well as we assess barriers to acute transitions. With Susan indicating, we talked last time about getting information from the state legislation data and MHA that would help us understand the volume as one way to start prioritizing. That's what the council has been talking about now. The link to the legislation for this council was posted in chat. Brad indicated through chat, insurance, flexible funds, appropriate access, I think, is also included or encapsulated further down in the bullet points on page 10. And then Jessica was brief in the data discussion, indicating that it would be nice to see the data, with Simon indicating the financial, uninsured, and homeless part will be huge, as those factors will have a direct impact on any systems that are put in place, as well as the correct assessment of individuals. Sounds like we need a checklist that every person goes through. It can be based on needs, care, facility, follow-up, evaluation, limitations, etc. Jessica had a comment in relation to the kind of visual representation of the data, questioning if there would be perhaps a one-page summary or infographic. I think those are things that Rachel and facilitators can take a look at. The motion was posted in chat regarding Rachel, or one of the facilitators, reaching out to Susan Pleasance to secure data and transfer data into a visually understandable format. Jessica shared an article that has a table, has source data from hospitals provided in it. That would be a great pathway that those data came from. And then the next motion, which I think was the fourth motion for the day that Jessica put forward, facilitators review literature and other data sources to identify original source data. That gets us up to speed with the chat.
Thank you so much, Jen. I really appreciate you keeping an eye on that chat. The one thing I wanted to say before we kind of start moving towards another part of our agenda is these were just notes. And so I've seen, the comments from Cindy and others. I think Brad was one that we need to wordsmith it a little bit and make sure that it covers the financial barrier situations, those kind of things. So our thoughts were, if we could kind of come to consensus that we're moving in the right direction, that this could be something that gets inserted in some sort of way into the report, but it's not meant to be set in stone. So I just wanted to mention that part as we kind of close on this section of the notes that we have. And this is kind of, we've already said that the council is only addressing supports for individuals with the characteristics above who've experienced acute care crisis resulting in hospital or out-of-home placement. But prevention-based strategies are recommended for all children and adults, right? So that report does need to kind of have that messaging that you all are talking about, that we are focused on a particular area, but we also recognize that a prevention-focused approach is going to try to reach out to a broader group of people and support them more effectively, either through policies or training or technical assistance or other types of services and that sort of thing. The part that we were also trying to articulate and wanted to get your feedback on was each individual in the list is experiencing certain systems, barriers, or other types of issues that are creating the transition problems. We were trying to kind of create a list that would explain the types of experiences in a way that would fit across these different children and adults. So there's no way to increase or allocate temporary funds needed for effective transitions, should that be what was the barrier was. Initiating transitions before training and supports are fully in place sometimes is one of the issues that comes up. Failure to communicate when transitions begin, or individuals are sent back to acute care settings, and we don't, some systems or groups don't know about it. No immediate problem solving when barriers are encountered. Leadership of intervention implementations unclear. So in meetings, it's not clear who should be taking the lead on things. And I mean, we've just had that experience ourselves with like, who is going to go get the data, right? So we've clarified that in our group. Good job. Lack of preparatory clinical support in the community settings. There's a lot of research literature out there saying it's very difficult to get access to certain types of physicians and psychiatrists and other people to help support things that are needed in the clinical realm. And then inability to increase the number of staff or supports temporarily during a transition. That's kind of linked to the funding issues. So those were some of the things that we talked about as sources of the challenges that are that lead to the transition problems. And then because of the population being so diverse, there are some unique care crisis sort of strategies that might work across these different populations of people. So we kind of listed some of those out as a way to kind of start the conversation about recommendations. Anyway, I don't know if it fits all of the different groups or populations or whether we're missing some things. So it might be good for us to have some time. I know processing on the run is not always the best way, but you could take some time to kind of think through what's written here, given that they're notes and they're not meant to be the report itself, but it would give us a way to start zeroing in on some of the issues. Laura and then Josh.
Yeah, so I just want a little clarification, like the staff piece for like support staff. It says temporary increase, but a lot of the barrier is not a temporary increase barrier. It is the inability to find appropriately trained staff and staff retention. So high turnover rates and just really chronic open positions that are unable to be filled. Do we have anything in this list that covers that?
Maybe not in the way that you've articulated, so we certainly can make sure that that's in there as a target bullet. And then Josh.
Yeah, I was just going to make a suggestion, you know, knowing that it's 122 and kind of going back to what you said about just doing this on the fly, you know, I'm wondering if we can assign some homework and between now and the next meeting, we take a look at this sheet with the bullet points, folks go back, talk to those that they work with, support, you know, others, and then maybe we pick a date or whatever, send that information back to you, Rachel or Jennifer, or to the email address for the Transitions Advisory Council. We get that back in, and then we can digest that maybe at the next meeting. It's a topic on there. I don't want to take away from the next agenda items, knowing we could probably have a really robust discussion about this right now. So that would be my suggestion, unless folks think that's not smart.
Agree.
Great. I think it's a great idea. It does give us just the amount of time we need to start transitioning to the other sections of the agenda. And for those of you live streaming, we will be having an open session as well. And so we have the email address that you can access from the Acute Care website to be able to kind of give us feedback from the general public as well. The next item on the agenda is Amy Peterson is going to present on the kinds of services that are available. Our idea today was to make sure that we kind of knew the state of the state. What is going on? What are our strengths and our needs within the state around the barriers that we know are occurring? And that would be something that just gives you some background as we continue with the assessment process. And so with that, we will transfer over to Amy.
Good afternoon. Can you hear me okay?
Perfect.
Excellent day. I am also here today with Juanita St. Croix, one of my colleagues. So we are both from the Transitions, Tribal and Transformations Division, which also houses the acute care or the complex transition team. Go to the next slide. So I added a few things in here that I thought would be helpful, perhaps also helpful to the conversation that we had here just a second ago. But grounding slides, again, hospital decompression, a lot of the efforts from the department were initially around literally in response to the public health emergency with COVID, make room in the hospital. And a lot of those same issues still exist today, as you guys know. However, we're shifting a lot of our focus around the individual and what they may need. What are the barriers for the individuals systemically at the person level and so on. Let's go to the next slide. System challenges. You guys nailed it in your conversation, is that we have an unknown number of people statewide that may be experiencing the hospital overstay as we've identified. There's a lot of different efforts going across the state as well as across the country. We are not alone in this. There are many states, and even my new colleague likes to point out this is also an issue in Canada. The short-term solutions, they've been challenging, but we're finding perhaps some ways to relieve some of those pressure points that I'll highlight, and looking at systemic opportunities to make changes and what's going to make the most positive effect as we look at regional options, because some of these are not necessarily universal to each hospital or area of what they're experiencing. Let's go to the next slide, please. So here's the what we've been asked to do with the acute care transitions or the complex transitions team is we started with a referral form. This referral form, I have a screenshot here of what this looks like. We've started with the hospitals and asked that please go ahead, send us a referral. If you have an individual that's experiencing an overstay, we will see what we can do to work with the county, the tribal nation, our respective areas within DHS to affect some positive outcomes for that person. Go to the next slide. So there's two components. Let's say we received that referral from the hospital as it is now. We're looking at it two ways. The person has a transition plan in place now, or maybe they don't. So if they do have a plan in place, what is it that we are doing now to help potentially affect some positive outcomes for that person? So it might be helping with the rate exception. Some of you that are in the field, you might know this as DWRS, or the disability rate system. Providing information or assistance navigating to partner areas within DHS. Maybe there's a licensing issue. Maybe they need to update their provider record with provider eligibility and compliance. We have access to some flexible state grant dollars if there is some sort of barrier that is preventing that transition, or if there's something we can do to expedite it that isn't already covered otherwise. And then connection to clinical consultation and training. One of those things that we'll also be looking at is, as we see these initial cases coming in, what else can we do to potentially affect positive outcomes? Now, the latter half, what if there's not a plan in place? What can we do? Similarly, a lot of the options that we saw on the other side is flexible use of grant dollars, technical assistance, rate exceptions, and then also, where are they headed? Where do they want to be? Do they have access to that next level of care? Go to the next one, please. Sorry, I jumped a little bit there. A couple of things that we have been doing for folks that don't have a plan in place is looking at referral options. A handful of residential providers have stepped forward and said that they're willing to work with us to develop some additional capacity and find some creative solutions that we could consider to, again, affect some positive outcomes for folks so they can get to the right place at the right time for that individual. And some that you've also talked about is person-centered planning, behavioral supports, and so on. Next piece, now that we look at some of these referrals that we've got, this information is a combination of two things. It's a combination of what we're receiving from the complex transition referral form. That's the one that went live in November, end of November, and information that we gathered during that portion of what I would call hospital decompression. So that was before we tried to put any of the supports in place through the acute care or the complex transition team. What we're seeing often is with youth, very often individuals engage with child welfare, Native American children and individuals of color, very much overrepresented in the data in the population. Autism with adults. Similarly, criminal histories, high medical needs or behavioral health needs, and multiple hostile stays going in, out. Overarching amongst those is really, again, that behavioral health, some of those behavioral support needs that they might need that might be more challenging to meet in the community. Very often trauma. If the person has been previously served by a provider in the community, on occasion we'll see where there's perhaps like this developed reputation of the person is really hard to serve. And it's almost like the longer that person is there, the more challenging it can be to get them back to community where they can be best served. We'll go to the next slide, please. A little bit of data. Let me put a caveat on this. So this is data that has been developed in respect to the complex transition referral form. We have asked the hospitals who are submitting this currently to limit their referrals, and that's due to our internal capacity as we build up a team. So please don't take this as a full scope of the issue with hospital overstays. This is a limited representation, perhaps some of the more complex patients that the hospitals have been prioritizing and asking for support. So take a little look there. You can also see, for example, highest levels of referrals currently are coming out of North Memorial, Essentia, Alina, St. Luke's, and limited referrals from some of our hospital partners down the road. We'll go to the next slide, please. The WHO, the individuals that we're seeing for age-wise, you can see smaller number of cases for youth, whereas highest chunk there is 22 to 64 years of age. And second is the 65 plus, somewhat even with adolescent or youth aged. And why they're coming, or what's the presenting issue that got them to the emergency room or the emergency department in the first place. We'll go to the next slide, please. Now, discharge plans. So if you remember, I said we are looking at this two ways when we receive that referral. Does the person have a discharge plan in place or no? Early information we received was that majority had plans in place. However, now that that's flipped a little bit, you can see about 2/3 do not have a discharge plan when we are receiving that referral. A lot of times what we're seeing thus far is that that number is being pushed up because of issues around like MA pending, where there's some sort of barrier or challenge in establishing either financial or functional eligibility for medical assistance or Medicaid. Perhaps it's navigating through like a medical review, or you've also heard the term SMRT, which is our state medical review team, where they'll do a functional eligibility. Maybe it's getting access to their financial documents, identifying assets, all the way through completing min choices assessments, rate negotiations, and similar that I had identified in the prior slide. And then when you look at the active versus resolved, we're looking at that from the perspective of trying to track these through discharge from the hospital. I think it's natural to expect that we are most often going to always have a high number of active cases versus resolved. It's a reflection of that incoming, and that sometimes these transitions take a while to occur, and making sure that person has the opportunity to get back to the community or the right level of care for their needs. So anticipate that active number always to be higher than resolved. We'll go to the next slide, please. Now, this is the services. This is where I think you were primarily looking to me to speak to, is what are the current services available for a person that wants to transition? There are a handful of services here that I have listed. There's also a nice comparison on one of the DHS web pages where it identifies the differences. I give you a little screenshot there. So the first service is Relocation Service Coordination, or often people will refer to it as RSC. That is a basic transition service. It might look like perhaps like a targeted case manager, where they're supporting that person to identify housing and services in the community. So they're coming from an institutional setting, such as a hospital or a nursing facility, or some alternate places. And it's truly just a support to help that person move. The next one, Moving Home Minnesota, that is part of the federal demonstration grant, from also known as Money Follows the Person. In Minnesota, we have relabeled that as Moving Home Minnesota. So that is very, very similar to Relocation Service Coordination. But on top of that, there's an additional menu of services that the person can access before, during, and after that transition back to the community. So that could be something as simple. Let's say that they want to access some specialized supplies and equipment, some home modifications, and so on. There's support in that area. There's some, also we've applied to CMS to expand that menu, but I'll come back once we have approval to talk about what those things are and how they can benefit our acute care transitions. The next is Housing Stabilization Services. This is another state plan service similar to Relocation Service Coordination, where it has 3 different phases where they're looking at a transition, sustaining, and I apologize, I'm going to forget the third one, where they have very similar services helping somebody move from various setting types, but also allows to help the homeless population. When it comes to transitions from acute care settings, this is not necessarily the most frequent service that people tap into for those needs. And the last is our waiver transitional services. This is a service that's available for those that might be accessing our aging and disability waivers. That is very, very similar to Relocation Service Coordination or Moving Home Minnesota, but it's a perhaps more limited benefit set for that person. So the most robust opportunity for folks is really through Moving Home Minnesota at this time. I want to pause there because this is, I think, where you were hoping me to hit is on the available services for individuals in transition. So questions, thoughts, comments?
Amy, maybe this is a stupid question. Everybody else knows this, but can you speak to, and I see it, never mind, it says it right there. Are there other services that folks can tap if they are not on a waiver? Because if that's a barrier to receiving these services, then it kind of mutes the effect or the positive effect of utilizing something like this if they're, maybe in a place where they're not already on a waiver, their waiver is turned off, or whatever, other things like that.
Yeah, that's a really great question. So what does it look like for a person that, depending on what their eligibility is, what could they use as a transition support to move back to community? So 2 of these, so Relocation Service Coordination and Moving Home Minnesota, if you're on the webpage, you could scroll a little bit further on that grid there, and it's going to talk about the eligible settings. Those 2 are going to talk about institutional settings. That's if somebody's, like I said, similarly is whether they're in hospital, nursing facility, some of our behavioral health services. So specifically, we have what's called an 1115 substance use disorder benefit. It's a demonstration project. So there is multiple facilities enrolled in that. So they would be eligible for Moving Home Minnesota. Housing stabilization services, you're going to find is the most flexible for an individual, regardless of setting. And then waiver is going to be when you're accessing waiver services, transitioning on to a waiver, et cetera. All of those are very, very flexible in terms of like what service they're going to. The waiver transitional services is going to apply waiver. So for specifically, let's say for Moving Home Minnesota, relocation service coordination and housing stabilization. All of those are going to be available to a person if they are going to reside in an eligible setting in the community, which is typically either their own home, a family home, or in some form of group living that is typically 4 or less individuals, or in compliance with what we call our home and community-based settings rule, which is making sure that it's an inclusive setting in the community. They are all available to a person regardless of what their eligibility is. So let's say, for example, for those of you familiar with the MnChoices assessment, that's looking at what they may be eligible for in terms of services supports, or like what level. Those services, those 3, they're going to be available no matter what. So let's say you have an individual in transition. They want to move into a group setting of some sort. And then maybe they're using waiver services, or maybe you have somebody moving into an 811 unit, and which is a housing voucher. They can do any of those in addition to accessing basic state plan services such as personal care assistance, or tapping on, adding on some waiver supports like our aging or disability waivers. They're going to be flexible to however they fall within that spectrum. That was a long answer, Josh. I hope I hit your question.
No, it's perfect.
Okay.
I have a question regarding like when you call it transition services, are these temporary? Like, is there a length of time that these, like, are they meant to be like a bridge, and then like you are then needing to find a different long-term service? Like, what is that meant to do?
Awesome. Yes. Each of them have different timelines that they are available. The one reason why I very much appreciate Moving Home Minnesota is that, similar with relocation service coordination, there's a 180-day time frame of eligibility to utilize that service for the transition. And as you guys know, which is part of the reason why we're here, is it doesn't always occur within 180 days or 6 months. It might take longer. And so with Moving Home Minnesota, what you can do is you can request extensions so that you can still keep looking for those options. So perhaps it might say, we will receive requests frequently saying that, we've exhausted options and we're looking now for X level of service or a new development to try and meet the needs of the individual because we're not finding it available within the community. And that's a flexibility that we have with that grant benefit.
Sheila, you want to go next?
Yeah, sure. Hey, thank you for the presentation. I'm just curious, from the state's perspective, do you have sufficient provider pool providing these services?
Ooh, that's a tough question. Almost chicken and egg, because we have quite a few providers, but there's also a question of whether they're being utilized to the full capacity or if that provider has the capacity within. So I'm not sure I could fully answer that. If we were talking about perhaps providers to serve people with complex needs, I think perhaps we're looking at trying to support the providers that maybe have the capacity, or if they don't, do they have the skills and the abilities to support somebody with complex needs? And how do we support that provider in a way that's meaningful for that person and the team?
Okay. And then my secondary question was just if you have any data on the effectiveness of these services. Do we know how many people that access these? Is there a percentage? And maybe it varies by the different services are able to be relocated using these services?
We certainly have utilization data. I'm not sure if we're how robust it's gonna be in terms of effectiveness from a qualitative standpoint. I mean, we could absolutely speak to which service worked, perhaps how long they used that transition benefit until they got to their preferred location or service level. That would be something that we could try and pull together.
Okay, I think that would be helpful. Good to understand. Thank you.
Randy and Tiffany, I think you were next.
Yeah, I just wanted to kind of say, so I am an RSC worker and I work with Moving Home Minnesota. But I also just wanted to explain, Randy's been on Moving Home Minnesota. And the one thing, like you said, the one thing really great about Moving Home Minnesota is they do allow changes. Randy's case has been very difficult due to a lot of different factors. And we just recently submitted his 4th extension. We're waiting for the approval. We just sent it this week because we're waiting for a specific house that's working on needs that are specifically for him. So I just wanted to say that I am what she's talking about as a worker who does that. There's many different agencies and all the things, but just wanted to kind of praise a little bit about that program as they have been able to give us extensions as we continue to work through the process. As Randy is one of those cases, this is why he's part of this committee, is that he's been in hospitals for very extended periods of times. He's been in nursing homes extended periods of times. There's not a lot of house settings that are able to meet his needs. He's not able to go home. And so without that program, the likelihood of him being stuck in a nursing facility for the rest of his life without the program would be likely where he would be at. And so I just wanted to give Amy Peterson a little bit of a shout out and saying that the program that does bring a lot of benefits. And I have moved, I have 3 moves scheduled for next week. The program is effective, but like I said, and I've kind of got a little bit in the earlier conversations even today, there's a lot of barriers of trying to navigate to get people through all those different pieces to get them out. And so I just wanted to say that.
Randy, thank you. Thank you for sharing that. I appreciate it.
Susan, I think you're up next.
I just have a question because I think it's super helpful to know what resources already exist, but you have a unique perspective. What do you think we need more of? Make this even better, because I think that's the goal of this group, is to help improve upon what already exists.
That's a really great question. Thank you for asking that. And I wish I could give you an easy answer. If it was just 1 or 2 things that I could tell you this is exactly what it is, and you guys do your magic. I think it's a really dynamic, multifaceted need. It's going to range from staffing for our providers. There's also knowledge transfer and building that capacity to serve somebody that might have complex needs. And when I say complex, that could mean many, many different things. It's not just one thing. And then a lot of it is also, sometimes it's funding for creativity, which we have been tapping some funds through our Transitions to Community state funded grant, as well as some money that was set aside from the American Rescue Plan. We had enhanced funds that we received through that. So that it's how do we bring all those things together? Also looking at our internal systems as a human services system and how somebody accesses, navigates, and gets to what's right for them. And it's a lot of things.
We might need a list.
We have this recorded. We can go back now.
Oh goodness, no backs. Okay.
Natasha, you were up next.
Yeah, I just wanted to respond to the question about kind of what's the state's position on what's needed. And I think, I rose my hand before Amy answered. I think that's a really good and comprehensive answer. I will say the way that I think about kind of where we identify gaps is, so, okay, we were just talking about the different services that are available to help people transition from institution to community. And we can certainly take a look at those services and say, is there a piece missing here in terms of facilitating a really quality transition? And that may be something we want to look at. In my view, as we've been doing this work and as Amy's team has been building out and doing this work, it does seem to me that the fundamental gap is something between is a combination of providers, right? So going back to the earlier comment that was made about the training and the training for provider and direct support staff and their kind of supervisors and supporters, because it's a special, people that are in this situation tend to have, again, those complex needs that require really specialized training. And so we can't assume that, anyone who just started in the field might be ready and prepared to do this type of work. So what do we need to do from a training and building out more providers that have capacity and skill to support people with complex needs, understanding that those needs are variable, right? It's not like we can just put everyone in one lump and say, if we trained everyone like this. Although I will say that I think if we looked at how do we have, especially direct support professionals and kind of their immediate supervisors that really had good capacity and positive behavior supports and positive supports overall, that would take us a long way, right? And that maybe is the foundation. And then people build up on specialized training that's particular to that individual's needs, whether that's medical, clinical or behavioral. So I do think there's a fundamental provider shortage in that regard. And the second piece that I'm less sure about, or I think gets a little bit, that scope starts to expand quickly, is the physical place for them to go. That's not an institution or a nursing home. And so I want to be careful that we, in this group, don't make assumptions that everyone needs to go into a licensed provider controlled setting. That might be true and necessary for many, for some parts of this population, that might be the right fit. But also, if we had sufficient staff, and I realize that's a hard if, some folks might do better in their own home with supports and services coming in and a combination of assistive technology and whatever, and natural supports, whatever that looks like. So I think the kind of housing piece is its own question in the sense of, do we have enough residential providers, right? Provider controlled settings that are licensed and regulated. Do we have enough of those? And if not, how do we build that capacity up? Understanding that when they purchase physical, buildings, they purchase homes, they lease apartments, that's one type of thing. And what are the right incentives for that? And then the second piece is, there enough affordable, accessible housing so that if someone is able to find staff and is able to find that magic combination of staffing supports and own home services, that they could actually afford to live there. So that's how I kind of think about, do we have sufficient? It's like, it seems to me the gaps that are harder to fill and harder to solve, we are related to housing and provider capacity building. And which does not mean we don't want to have a conversation about, is there something that needs to be added to the service of relocation, whether it's housing stabilization or moving home Minnesota. We certainly can if that's of interest to this group, but I don't see that piece as the more fundamental gap. So I just wanted to share that.
No, I think it was beautifully stated. Thank you, Natasha. And so Nicole, we'll wrap up with you before we head into the break here.
Yeah, thanks so much. And Amy, thanks so much for your presentation. Super helpful. One of the things that was just coming up for me, just in from the provider aspect is, we came to the calling to help with a youth care transition team to help in the metro and southern area and help youth transition from hospital settings into their homes, residential settings, foster care, but just really help with that transition and wrap around them. But we know that funding for innovative programs like that doesn't last very long, right? For us to be able to create these innovative programs to kind of meet a need, but then sustain them long term. And I just wonder if there's opportunities to look at any of these funding sources and things to help sustain innovation that meets needs to cover gaps. And what that might be, because we know that everyone has very individualized needs. And so having teams of folks that can wrap around, especially when we're talking about youth, but I think it does go for adults too, you know, if they need a behavior specialist or they don't, if they need a skills worker or they don't, if the family needs intensive in-home therapy or they don't, and what that real need is in order to help that transition, and then have that team stay in the home for a period of time, right? So to make sure that that transition is a successful one, and that the outcome is that we're able to maintain them in their home. And so it's not a continued revolving door within the acute care facility. So that's the only other thing that I wanted to add is I wonder if there's ever any sort of ability to look at things more flexibly sometimes within some of those funding streams. As I know each of them kind of have strict parameters around use and access. So
Yeah, thank you for the question. So funding streams, current funding streams, I can speak to, and perhaps Natasha wants to tap in at the end here. What we're doing is with Moving Home Minnesota, it's a money follows the person demonstration. That's the federal name. We call it Moving Home Minnesota at the state level. With that, it's offering a level of flexibility for the state to design what services supports may be needed for us as a state. We've been utilizing those funds to build up the complex or the acute care and the complex transition team. So that's one example. Also in terms of like services, that wraparound supports that you're referencing. Again, that's another fantastic funding stream because it allows for some of those services to be billed while the person is still in that institutional setting, following along into community, and it can follow for that person up to the first year. If they still have, or perhaps even in the first place, they can also access waiver services on top of that. So again, that could be like your elderly waiver, CAC, CADI, BI, DD. Those, I just threw a lot of acronyms at you. Those are your disability waivers, such as like the developmental disability waiver. Those can be braided together. They can run concurrently, utilizing that Moving Home Minnesota benefit to add on those additional supports for that first year in the community when that person might have more intensive needs until they can find that rhythm, the right rhythm for that person. And hopefully they're in a great place there. The other funding piece that we've been tapping is the Transition to Community state grant. That's a state funded grant that's existed, I want to say 2013, I think. Flexible funds been really great. We're utilizing some of that now when we're looking at individual cases and how can we support or facilitate, expedite, whatever verb you want to toss on there to help that person get welcome back into the community or to the right level of care for them, whether that be with a group residential provider or in their own home and so on. Last is the third funding stream is we've been utilizing some of those ARPA funds, the American Rescue Plan Act funds that we received as a state and directing it towards the acute care transitions. In terms of sustainability, I think this is where this team comes in, and maybe Natasha, you want to speak a little bit to that and anything I might have missed?
Yeah, happy to. And I think it's a really important question to ask. And I want to add a little bit to what Amy shared. So in terms of, talking about what services have flexibility, if we maybe decide that, or this group recommends that we want to change something, whether it's relocation services or a different type of service, just as a kind of a high level matter, typically services that are in our waivers are in our federal waiver plan, which is our agreement with CMS about how we're going to spend their money. And then they often, not always, have a connection to an authorizing state statute. And so when we seek to make changes to those services, which are built into our budget and our forecast, if we were to make changes to make them more expansive, more eligibility, whatever, anything other than cut, we would need a statutory change probably in state, and then that would direct us to update the waiver plan, and there would likely be a cost to the overall budget forecast. So in that sense, we have not as much flexibility. Doesn't mean we can't change it ever, right? Please don't, I'm not trying to say that like nothing could ever change, but it does require, again, moving through the legislative process. But that's what this task force is also set up to do, which is to make recommendations that therefore inform legislative bills and language that we would want to bring forward in subsequent sessions. So just to know that when we're talking about the waivers, typically we need a statutory change unless it's a tweak that isn't expected to have a cost and doesn't change things. Moving home Minnesota, Amy is absolutely the expert on the level of flexibility that's available. So I won't speak to that. I think she did a good job with that. But the same thing, for housing stabilization services, for example, or support services, those are not a waivered service, but they are in our state plan or our plan with CMS. So the same types of rules in terms of if it has a cost, we need authority and we need to make statutory changes. So that's kind of the flexibility piece. But what I want to also make sure that I put on the table for this group is if we as a group, as members, are making recommendations about what we want to change, right? We really focus on what's missing, what needs to be added, what maybe there's something we find that needs to be taken away. We can then in DHS come in and say, okay, here are the technical options for making that change. Maybe we can do some things with a small grant and we want to try that. Or we could go, the whole enchilada and seek a legislative amendment. So we can, once you feel like we as a council have settled on the kind of the what of our recommendations, we are also here at the department to provide kind of that technical assistance about here's how you could go about making that change. Sometimes we're going to have a couple options, and then other times it might be only this. And so it's not to say that these aren't important conversations. Of course they are, but I encourage us not to get too bogged down into what would it take. I think we're much more wanting to make sure we get at what would be the real things that you all see that would help. And then we can, at a subsequent meeting or a subsequent communication, come back and say, here's how we could implement those things if it were implemented. So that's the one piece I wanted to share kind of on the flexibility side of things. And then just also, as Amy said, the transitions to community is state grant dollars that we have been really trying to wrap our arms around and leverage. And it was additional funding provided through the American Rescue Plan Act that last session we're able to convert into general fund dollars, but the general fund dollars are time limited. They have I think a carry forward into 27, if I'm not mistaken. So that money, that money will eventually sunset if the legislature doesn't take action. So I think one of the things for all of us to keep our minds on in terms of that super flexible funding, because that funding is very flexible, but it has to go through a grant contract process. That's the one limitation right now. And that could potentially change if we want to make that recommendation. But if it's valuable to have that type of flexible state grant dollar on the table, that would be something that we would want to include in our legislative report, because the money, we're doing a really good job starting to get it out the door now, but it doesn't last. It's not in the base budget. So, and I can share more technical details on that if we need to, but I just wanted to also add that piece for it. And whenever the department is administering, especially a flexible grant program where we have a lot of discretion, we are also, of course, worried about being able to do things correctly, document them so that if we're audited by the legislative auditor or whatever, that we followed all the rules that we're supposed to follow. And sometimes following those rules creates delay. And we also know time is of the essence here. So we could also talk about later if there is an appetite to keep that fund or kind of fund it as a recommendation, whether there might be some administrative flexibility that we would want to look at, and we could come and talk to you about that too. So I know that's a lot on the flexibility side, but I just wanted to go on record saying we can help you kind of figure out how to do a thing if we decide as a group what we want to do. And then the transitions to community fund is available through 27, but as of right now isn't reauthorized beyond that. Other than the 1.8 base appropriation, which is usually spent every year on existing programs.
Awesome. Well, that was a lot.
I'm sorry, Mr. Chair.
No, it's fantastic. And the discussion too. So before we go into a break, I just want to ask Jennifer and Rachel, do we want to go through, there's been a lot in the chat as well. Do we want to hit on that? Do we want to take a quick break and come back and see if, I'm taking my question back. Let's take a quick break. We'll take a break until, let's do 2:10 or 2:15. Somebody say something.
2:15.
2:15. We'll come back at 2:15 and then we'll adjust the timeline a bit and then we'll go from there. So thank you, everybody.
The public forum will be either right after the break or after they do chats for breaks.
Okay,
So
great.
it's up on, next on the agenda.
Thank you.
Thanks, Amy. Done.
All right, it is 2:16. Sorry for that. And just
Josh,
wanted to.
I'm gonna make a suggestion, which is instead of me presenting all of the 25 minutes, that I just do a couple things and lead us to kind of the open session, given the time.
Sure.
Is that okay with you all?
Yeah, no, I think we can present whatever we need to. We'll get through there, and as long as we get to the open session by 2:50, you know, and get to the group activity in between there, that sounds great. I do just quickly want to say a shout out and a thank you, and I still see Amy's on here, to thank Amy for that presentation. That was super helpful, super in depth, and I think it just kind of set the stage a bit. So thank you very much, Amy, for coming to do that. All right, turn it over to you, Rachel.
All right, so I thought since the discussion has been going so well that we might, instead of going through the PowerPoint slides that I have under my section, which is the positive support, training, and technical assistance, that we kind of take some time to put what we've talked about into a context so that we can continue moving forward. What we're going to do in the agenda is, you know, kind of move towards a group discussion about strengths and needs. And so this could be a way to move towards the open session and make sense for folks where I think we're headed. And you can certainly kind of redirect, but the brief that was sent out had a triangle in it, and it was meant to kind of talk about the acute care issues that we have that we must address immediately as a sort of that crisis response and reactive sort of fixing of the problem. At the same time, there's also what everybody's been talking about, which is how do we make sure that we are working on prevention and addressing those issues that are underneath this, that are causing a lot of the problems. It's a very complex issue. And so what I thought we would do as part of our discussion is kind of move towards a visual that might help us as we're doing the report. We looked at this in the implementation science area. I need to move my box here. I can't get to, there it is. Where we talked about in organizations, there might be all people receiving certain types of supports and services. Some people need a little bit more support, and a few people are having those challenges where transitions are difficult from acute care settings. There may be the possibility of going to the emergency room because of increasing challenges that are going on within a person's life. And so when we think about this tiered prevention sort of approach, we can apply this at the state level. And so as an example, Nicole was talking about a wraparound process for a few people that need to have that really supportive, flexible funding to get through whatever transition issues are going on. And as Laura said, having the standard sort of supports in place are important as well. But if you think about the tiered model, what we can do is look at the types of things that we as a state feel that we need. And the brief, just as an aside, was not meant to say these are the things that the council believes in. It's really meant to give you some ideas about how we could move forward in a way that looks at a layered approach. We definitely need to do the acute care issues and really address the emergency room transition process back into the community, but we also need to make sure that the community has the supports they need to make sure that when people are in their home communities, they have the supports that they need. So if we think about this from this triangle sort of perspective, what happens is we look at the 3 tiers and we think about state level discussions that we've been having. So if we think about that tier 3, we heard Nicole talking about having some flex so that we can wrap services around somebody, having a point of contact person that if we run into barriers, they can help support moving through those issues, certification and linkages that would help, for instance, if I'm learning positive behavior support or cognitive behavior therapy or other types of clinical approaches or behavioral support systems, that there's a way to have some incentives for people to be able to access either reimbursement funds through the waiver or other types of things. System issues are also around encouraging the things we've heard, for instance, in our region, is that if you have children or adults who have gone to the metro area, but then they're going back to their homes in a rural area within Minnesota, having memorandums of agreement so people can have conversations across the different settings in a way that's HIPAA compliant and allows us to make that kind of wraparound problem solving happen can be really helpful. So when we think about the types of things that you're talking about today, this could be one way to kind of organize your thoughts around what's more focused on the acute care issue itself, what things are focused on regions. So I know we've had conversations about regional supports and making sure that within our regions, there are ways to prevent challenges from escalating, and that we have regional teams and processes that help us really monitor what's going on. And if we had data that allows us to do that, we would be able to prevent emergency room settings from occurring, because we would be able to kind of problem solve before something becomes a crisis and ends up in the emergency room sort of setting occurring. And so when we think about tier 2, that's kind of a regional process that could happen. And I know that Moving Home Minnesota has regional sort of pieces to it. There's some other things that I'll be talking about that has to do with regional kind of capacity building and that sort of thing. And then there's the cross division around sort of the tier 1, which is how do we really think about making sure that, like you said, Laura, that we have staff that are available, that there are ways for incentives to occur for provider organizations to get access to different types of trainings and supports to be able to do what they want to do. And then also looking again at that data sort of issue. So when we think about what you've all been talking about today, some of them have, the comments have fallen into these different categories. And so I was just curious to see if this might be one way to organize our brainstorming around recommendations. So I thought I'd just open that instead of going through all of the details of different positive supports that are available. So that gives us a way to kind of continue the conversation that we've been having. Laura, go ahead.
I was just kind of curious, like when we're talking about incentives for providers, like, should we address the large pay gap between in-hospital salaries versus community settings, which naturally would gravitate direct support persons, whether they're RNs or like aides, things like that, to be in the hospital setting, because that's where you get your best protection and your best pay. Should that be something we look at, or is that beyond what our capability is?
Well, I would let Natasha speak to that, but I think what she's telling us to do is kind of think about what are the needs, and then some of those things are going to be feasible with the funds we have, and some are going to be we're not going to be able to do that without changing statute and actually going through a process. But I think and Natasha, you tell me, this seems to be like the brainstorming place that we can talk about all of the things that we believe would make a difference in this situation. Natasha, is that kind of in the ballpark? Are you on mute? You don't look like you're on mute. Oh yeah, you do look like you're on mute.
Can you hear me now?
Yes. No, maybe not. Are you still talking?
I think the DHS room has to be unmuted from their end.
Ah. So Jen, are you saying that Natasha needs to get assistance?
That could be.
Yeah. Oh, that's unfortunate. Okay, well, we'll give Natasha some time to work on that, Laura. But I do think that might be the way to kind of think about this, that some things are really large, and you went to like the big picture, which is if we don't have incentives for direct support staff to be in jobs in the community, then we're not going to be as successful. There's other things though, Laura, that also kind of go along with that, which is like if there are ways to have a professional career path within an organization, right? So these are things that are being discussed. And I think that if we were as a council to think about all of these types of ideas and then prioritize the things that you believe are the most important and then make those recommendations, then it becomes a pathway that helps the process. Josh, go ahead.
Well, I was just going to ask the question of, so is this where we want to move into the group discussion, the group activity piece? And then if so, how do you want to facilitate that? Like, what is going to make this the most useful time to have everybody start to share, and how do we want to actually tackle that? Because I'm sure there's lots of ideas based on this as the framework.
I mean, I think our decision has been to stay as a larger group and not to do breakouts. That was, something that we talked about in our chair meeting. What we certainly could do is just create, blank boxes and put those ideas in. So Laura, your idea that you're speaking to me fits within the universal level. Is that kind of what you're thinking? Okay, so what I'll do is just kind of take this document and kind of take notes as people are sharing, and we'll put them in the different areas. Does that work for you, Josh?
Yeah, no, and now I just encourage people to start putting their hands up because I know this group has a lot of ideas. And I just wanted to make sure people knew that that was the time to start doing that.
I also just wanted to interject. It looks like the DHS room is unmuted. So,
Natasha, would you like to jump in with this conversation as we're headed towards the activity?
Sure, test. Can you hear me?
Yes.
Success. Sorry about that, everyone. So a couple things I would say regarding the question of sort of what's in and out of scope in terms of wages, right? As particularly if we compare wages in acute care settings versus community-based service providers. So I definitely think that that's in scope for the report if the group really feels that that is the fundamental problem, right? Or one of the fundamental problems, that if you think it's about raising wages, and we think that if we raised everyone's wages by X%, and that would relieve a big part or solve part of the problem, then that should be in the report. What I will say is that I think there is a lot of activity in different sectors across the state on wages for HCBS workers, direct support professionals, whether, certified nursing assistants versus home and community-based services workers. So I think the question and the amount of money available in the state budget to pay for those rate increases is, very fundamentally a legislative decision. So my sense is that, it's not appropriate for me at DHS to direct what these groups' recommendations are, right? My input is one member's input, but just thinking about if we did that, if we said we want everyone to be at X number of dollars an hour, does that fundamentally improve the systemic problem that we've been asked to solve? And I don't know what the answer to that is. So that's how it's a tough question because it becomes a little bit chicken and eggy in the sense of if we paid people more, we'd have more people, right, to do the work, to find the places. But at the same time, there isn't an unlimited amount of money in the state budget that has to pay for a lot of really good, important things like education, like law enforcement, other types of social services and supports. And so I think if we were to come to the legislature and with an ask of $1 billion, I'm just making up a number here, to make parity between hospitals and home care workers, I don't think that would fundamentally have a chance of really moving the needle from a legislative perspective, because they have too much to balance. So I think we need to be, in crafting our recommendations, you know, somewhat realistic about what's possible and designing our recommendations around that. But other people in this council could, I think reasonable minds could disagree and say, no, we want to shoot for the moon, and we understand that that's what's going to happen. So I do think fundamentally it's a group decision, you know, as any recommendation for this report will be. It's also, I'm sorry, last thing I'll say, it's also possible to include that recommendation along with every other types of recommendations, right? And then but I think it's helpful to know too, as we get into more final decisions about content, and we're certainly not there yet, for us to have a mechanism to gauge support from each member about what are the most important things, so that we have an actionable report where maybe we say, you know, if we do these 10 things, this would really make a difference. And if we could also have this thing, that would be even better, right? To sort of think about that, and framing our recommendations based on what's realistic and optimistic in the state budget. That would be my thought.
This is
Yeah, and Laura, you were next. You had your hand up.
County. I think we would just really want to be careful, if we're putting down that recommendation, that we'd fully vetted that. I mean, it's always easier to say, you know, that we think people should make more money, but I would be uncomfortable doing that without really investigating and doing comparables and all of those things. And I'm not necessarily sure if that's what we should be doing, or if there's more of an overarching recommendation to have a comprehensive evaluation of the salaries of these positions assessed. But I would have a hard time making an opinion that they're not being paid enough, just based off of kind of, you know, that's a real big statement. And so I would want to make sure that we do our due diligence or request a different entity to do an evaluation or something like that.
So did you call on me?
Yeah, go ahead.
Okay. So like two thoughts on that. I do appreciate Janelle's perspective on that. But I do have a lot of personal engagement with direct support staff and home care nursing type staff that have said some of the reasons that they don't stay in that field is because they make more in the hospital setting, and it's not financially, like they have to choose between their finances and wanting to provide services in the community, basically. And then if we're not able to do like a salary type incentive, is there a way to, I don't know, make people that are in community-based services eligible for like a tax credit or like a tuition thing that they could apply for within the states, that so then it's not necessarily a direct payment, but they get that financial incentive in other ways, if that makes sense.
Yeah, I mean, I think it does. And I think, okay, so I want to move us forward a little bit. I guess, thank you, Natasha, too, for the comments about the budget piece and the fiscal side of things. I think, at least in my brain, as of right now, you know, I think we look for the solutions. We do have to be cognizant and aware of, though, the realistic nature of them. And you know, as was talked about at the Priority Admissions Task Force hearing, whenever that was, I mean, we got to think through it. Maybe it doesn't define the solutions we have, but we should probably be factoring those in of, you know, we can come up with all these pipe dreams and think that this all sounds fantastic, but if the state can't afford it and we can't do anything about it, then we've kind of wasted our time. So we got to find that balance. So I want to move us forward and see Susan, and then we can kind of click through and get to some of these solutions that we can get started to document and talk through.
And before you talk, Susan, just know that this is the assessment process. We're not coming up with any final recommendations. We're trying to figure out what data do we need to look for. This is a very complicated topic. So go ahead, Susan.
We're just gonna maybe take the idea of paying people more back a level, which is to say, I think we need to figure out what things we need in order to create solutions, and then use something like a 5 whys, like, well, why don't we have enough of that? And maybe that's one of the reasons that people aren't paid enough. But we wouldn't want to just blanket say everybody working in this space needs to be paid more, because I'm not sure that is the general problem. I mean, we have lots of places for people to go, and so we don't want to just solve everything there. It's what are the services that are missing or are inadequate, and then what are the reasons that they're inadequate is sort of the next question. And when we might uncover that salary is one of those, but I'm not sure we've defined the gaps well enough yet to get to that level of solution.
So you're suggesting a gap analysis sort of approach to the problem. Is that right? Is that what you're saying,
Yes.
Susan?
Yes, sorry, I was nodding, which
Oh, okay, sorry, I didn't see the nodding. I was looking at you. And again, this is meant to like get us started, like if we know we need to look at different sources of data or different areas, we need to be thinking about the things that you all are talking about right now and how they fit with our discussion. So incentives are something that we know are really important for people to want to engage in different types of work. And we know that in states, a common strategy is to look at, is there access to reimbursement monies for waiver services? Are there things that we can do to connect? So for instance, right now, there's a positive support service that's part of the home and community-based waiver, that if we were to look at ways to provide training and technical assistance that people can become certified or access information, or more funds or organizations can benefit in some way, those are things that we could consider as a way to set the stage for people to really think about universal strategies. I think most of our conversations today have been around that acute care sort of area. And Nicole, I wanted to try to capture what you were saying around wraparound and making sure that we're thinking about ways to be flexible and supporting and creating teams. Can you talk a little bit about what you would think we would need to look into on that? To me, I'm thinking wraparound planning, systems of care. Is that kind of what you were talking about?
Yeah, I that was my nod to that, but then also sustainable funding for programs like that. Which I know that we're not having a scarcity mindset. And so I appreciated, that kind of nod to that. So, but I think around sustainable funding for things like wraparound, system of care models, and do we have those within our communities that are accessible? Or do we have ways that we can access them despite where you might live or what hospital you're accessing? And to someone else's point of like, you're going to a larger metro hospital and then stepping down to a local hospital. But to do some of those wraparound or system of care models exist across the state. And so it's not just individualized to one area, but it might need to look different based on the services within that community. And so again, kind of a nod to systems of care there. And so those were a few of my thoughts around that wraparound model for transitions.
I think you're also speaking maybe to the regional level too, Nicole. So should we kind of think about it in that like, I think what you're saying is, what do we know about what's happening here? I'm in the wrong place. Sorry. What do we know about what's happening in our different regions? I know for sure there's a SAMHSA grant that's in, unfolding right now. I don't know exactly where it is, but we could find out from our colleagues at the state where that's occurring, how different, I was just having a conversation with another group and they were talking about the wraparound planning occurring in the state of Minnesota. And I don't really know what's happening. And I would love to hear more about that. So I think you're speaking to like at the tier 3 level, having the funds to have sustainable teams, but then also at that tier 2 level, when we think about regional supports, that there's a way to encourage that systems of care at that regional level too.
Yeah, I mean, that's what I would be looking to have considered, that it's not just specific to one area, but how do we make this something that could be statewide?
Tailored to areas, but statewide.
Mhm.
So this suggests we might want to be looking for sort of more information from an assessment point of view about what's happening in the state of Minnesota, maybe some model demonstrations from other states, right? So from a lit review kind of point of view, I know there's a lot of different implementation efforts going on that we could kind of maybe do a part of the lit search could focus on that.
Yeah.
Okay. So let me just write, I'm going to go ahead and put that in the tier 3 section. What other states are doing. Great, thank you. Is there anything at the universal level, Nicole, that you can think of that fits within this this area? It's almost like maybe just awareness that, you know, the key features of what makes for good wraparound.
Yeah, I mean, there's like high fidelity wraparound programs, and, you know, things like that, you know, we could definitely look at the different programs that are available around wraparound. I guess when I was thinking about this, around the kind of this brainstorming the assessment, it was kind of bringing me back to when folks were talking about salary levels for direct support, but what are those services that people are looking for to help them transition out? So not sure if it is direct support, right? Like, is it primarily housing? And so does the focus really need to be around housing, because that is what individuals are looking for? But I know some of that hospital data was a little bit limited, so I don't know if we can gain some more access to some of that. And I know there was some comments in the chat about the ability to get access to some of that data. So
what did you say, Nicole? You said housing.
I don't know if it's housing is more of the need, right? So like, is it direct support staff? Is it housing, and is it residential placements? Is it support so that they can actually just go back to their home? And so is it behavior specialists? Is it therapists that will come in the home? Is it, you know, transportation? You know, like what are the things?
Okay, so that goes back to the, I don't remember which one of you talked about this, but the gap analysis of the right? So we're back at that gap analysis of the major issues that would make a difference. And go ahead, Brad, and offer people your thoughts.
So I was focusing a little bit on tier 2, which is the regional stuff on it. And I guess the overarching question I think this group might be able to contribute some positive thoughts on is what's the best model for the regions? What do the regions look like? You know, is it a northern Minnesota, central Minnesota, southern Minnesota region, or is it, I have advocated that there are some advantages to taking a look at a map of the state of Minnesota and looking at the judicial districts. Because those counties within those judicial districts are used to working with one another. And there's a district-wide office for the courts. And I've wondered, you know, even though a county might not be able to adequately address issues, a district might, because they're used to collaborating with one another, and they're used to reaching out as a district for funding for their region or their area. And I've wondered how I might be able to contribute to a positive conversation about, for example, a district-wide mental health court, or something that's like a problem-solving court to help people navigate their way through systems. We do that with veterans, for example. When veterans come into contact with the criminal justice system, really our goal with them is rehabilitation and reentry. And so the goal is not to get, it's a part of the function, but the goal is ultimately not to get to a conviction. In fact, we've evolved to a point in Minnesota where if you're in Veterans Court and you successfully complete the programming in Veterans Court, you leave without a conviction. So the whole focus is really on rehabilitation and reentry. And I'm wondering if we could leverage some of the ideas that have come out of that and getting judges and social workers and public health and counties and county boards to work better together than they have when it's just left to county by county on that. And I'd be happy to pull together for this group, just a simple district court map so you can see what that looks like around the state of Minnesota, and probably talk a little bit about why there might be some advantages to that. But I'm not suggesting that's the perfect model. I'm just suggesting that's a model that already exists. So, thank you.
Okay. Thank you so much. That's really helpful. I'm just trying to capture all this. We can look at different models, right? And there is before Josh and Laura, a question for Amy Peterson. I know Moving Home Minnesota has a regional component to it, and I know there are different regional efforts going on, including the one that Brad's talking about. So it's like really doing an assessment of what are the resources out there for our regional work, and how can we maybe do better at connecting them? Kind of that goes along with what Brad you're saying. So Amy, could you just tell us a little bit about what is going on with Moving Home Minnesota?
Yeah, so as a component of the complex or the acute care and complex transition team, we are developing a regional team. So they'll be embedded across the state, 2 in the northern half of Minnesota, 2 in the southern half, and 2 across the Metro St. Cloud area. And part of their initial focus is going to be on intake of those the complex transition referrals and helping to navigate through that. But part of their role is also really identifying regional trends, what they need, working with the counties. And really, I suppose I should just say that's it's in infancy. And as we continue to grow and learn, we can build more into that. It's also piggybacked off of the adult mental health initiative regions, and also allows us to, in the human services or social services world, there's also what we call our regions that we use in the aging and disability services world. So Lucy will be able to work with those regions as well, because sometimes there's county collaboratives that support people, like the case management aspect. So that's where we're starting in the regional model with the complex transition team.
Thank you. Okay. Yeah. I think Laura was first. I don't know where Josh is. You disappeared, Josh. So go ahead, Laura.
Josh said he was good. Amy just answered his question.
Oh, okay.
And then, so my thought is, and I don't know if it would go under tier 1 or tier 2, would be to, and I think I said this in the chat, maximize our benefit of the encounters by providing any assessments as much as possible, while they're in the stay and as early as possible in the stay, depending on the situation, because then it limits that wait list time when you're leaving, and it also lets you know what potential challenges might be coming up to implementing those services. Like, say if you have a special needs child and they need neuropsych testing, but they don't do it in the hospital, but you can't get it, the other services, till you get that, right? Then that's another delay. But if you could provide, since you're already in the hospital setting, that type of assessment, then now they're already in line to be on the wait list to get said services, and just kind of that fast tracking, I guess, if that makes sense.
So what would we need to explore, Laura, for this one? To know, I guess,
maximizing like case management assessment abilities in hospital setting or provider encounter settings. especially for those rural individuals, if they're coming to the cities, they have more access to those assessment pieces than they would necessarily maybe in their rural setting. And so instead of making them then have to come down for another appointment or something like that to get more access, they're already here. Let's get that gatekeeping thing done while they're in. Do you know what I mean?
Yeah, so what are the current strengths and weaknesses of this part of the process is kind of what you're looking at?
That and just the assessment pieces that can occur while in hospital, because sometimes it becomes disjointed between inpatient services and outpatient services, and that disconnect can create extra delays and hurdles, but you can do both things possibly, if that makes sense.
Yep. Okay. Randy.
We wanted to kind of go off of what Amy Peterson was talking about. A lot of times I get contacted really regularly from nursing home social workers, a lot, even hospital social workers, on how to get people enrolled onto the RSC and Move in Home Minnesota. And I think that there's some disconnect. I'm not quite sure where this fits in, but I'm just saying there is a lot of disconnect between a lot of the people not knowing how to access these programs. Because I get literally probably once a week, I get from a nursing home saying, hey, you worked really great with this client. How do we get more of our clients who are in the same position, stuck in this position? And I know I've worked with a lot of people in hospitals in the same things, and hospitals oftentimes don't know this. And I work a lot of times, I feel like the metro area, there's a lot of knowledge, but I think moving out farther, I've got contacted. I have a client in Red Wing, Rochester, and those kind of areas, they don't really know about these programs. And I think that might also help transition people out, is to try to inform people about the programs that are out there. So I just wanted to say that, because it's a very common thing. And I know that even talking with economic assistance workers, they don't offer on different things that they know clients are eligible for programs. They do not have to inform people of programs that they are eligible for unless the client requests those programs. That is a huge thing. This is coming from Anoka County, Hennepin County. EA workers, even if they know they're eligible for a program, they are told they don't have to tell somebody that they're eligible for these programs, that they should know about them and then request them. And not really about the relocation piece, but just even for services. Spousal allowance. This is if the person's in the hospital, their spouse, they won't offer those kind of support without the people knowing, and those resources are not known.
Okay, so I have just put this in the tier 2 section, which is if we're looking at a regional model where we're trying to get information out before there's challenges, that we have a way to first assess what are we already doing and what are the things we can do to improve on that area. Okay, Natasha.
Yeah, thanks. Just wanted to offer a couple things building off what Amy talked about. So, the department and the team that Amy's building with those Moving Home Minnesota funded positions, we are, really sort of building it as we fly the plane, or whatever the appropriate metaphor is. So one of the things I wanted to make sure I communicated with this group is that, if you want to make recommendations about how to best utilize or structure the work of the Complex Transitions Unit in context of your other legislative recommendations, I think we'd be really open to that feedback. So maybe just to put like something concrete on it. So you've heard how we sort of built those regions about the Adult Mental Health Collaborative, because that's some initial feedback we got from counties, and we needed to do something, right? We needed to put some teams in place and make some decisions. If, for example, this group thinks that a better approach is to look at the judicial districts, we would take that recommendation. We don't probably have enough of those positions yet, right? But that could be something we could build towards, where we could say, okay, the complex team is going to restructure their regions based on judicial districts, and we need 3 more positions. Or I'm just sort of making those numbers up. But I just wanted to make sure, one of the reasons we wanted to bring Amy here to kind of share is that we have a lot of work that's in process at the department as our kind of responsibility. And I hope that this group will feel comfortable as we move forward and you learn more about their work, saying, well, if your team did this instead of that, that would be more helpful, right? Or we can kind of talk about what gaps we can fill in. So as we talk about what's in scope and out of scope for this recommendation, I don't want to, open the door so broadly into all aspects of our work, because that, if the department just becomes completely unwieldy and unreasonable. But we can really have a conversation, and I know Amy and I are very open to a conversation from this group as you build recommendations about, if we decide a regional approach is appropriate, what should those regions be, and what part should DHS play in facilitating those regions of things? What are they supposed to do? If you want DHS to help administer them, which is, there are resources for that already, what would that look like? So I just wanted to put that offer on the table for you all to think about as we're developing recommendations, that we're looking at legislative changes, but you can also make recommendations in that report to say the department should do blah, 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 right? Or we should do training and, training for hospital case manager or hospital discharge planners on X, Y, and Z. Might cost a little bit of money, right? But typically that's something that, you could potentially sort of say the department should do X, Y, and Z. And then that might be a cost to that, but giving us that direction to structure our work in a way that meets this need is the goal of this council. And we have some resources that are at the table right now that we could restructure. So we're just open to that feedback, I think, is the main message. Because we don't know exactly the best way to do this. All the work of the Complex Transitions Unit is brand new work for us at the department, and we're very much trying to figure it out as we go along. And we know that we need community input in order to make it the most effective possible. So that's one piece. The second piece is just kind of going back to some things that Laura shared or others about kind of knowledge gaps. Is one idea we've been talking about quite a bit in the department is the idea of, understanding that counties don't always have the time, resources, or knowledge base to know everything about long-term care options, right? I mean, it kind of is like you have to find the right person. So the EA worker may not know anything about long-term services and supports, or they might be the same person in a small county, right? There's just so much variation in how people get information. We've thought about, and the idea of creating, a service under Medicaid or something else that would be like a long-term care services navigator, someone that doesn't work, that is compensated in other ways, but to say, okay, here's actually how a waiver works, or here's the moving home, and here's all the resources to get out of an institution, and here's how you would apply and be able to actually follow along and help that person, including things like completing a Medicaid application when there's a long-term care spend down, right? Like that's so complicated, and often those things drive people into more restrictive settings than they need to be in simply because of system navigation. So I'd be interested at a later date, offline or online, to just hear if that kind of idea makes sense to people, or if it's just building another duplicative service on top of a system, right? I think that's kind of the question about it. So wanted to put that out there as an idea.
Okay, and I'm going to jump in and say, aren't we supposed to be moving to open session now? Is that 2:50? So I know we've got a few more people that want to make comments, and I do assure you, as soon as we finish the open session, we can come back to this and finish our thoughts. So I know Brad and Jessica and some others. Am I right, Brad? Are you here, Brad?
Well, I've got to leave in about 5-10 minutes right now, and I would say this in open session too. So can I just throw my 2 cents in?
Okay, yeah. Let's call it the open session and let Brad speak before he leaves.
Thank you. I just wanted to say I super appreciate DHS's willingness to consider various different models for this stuff. And the one bit that I want to throw in at this point is I would like this group to think about, there may be some things that are achievable in the short term, but there are things that we should be working toward in the long term. So for example, I heard this wonderful thing today that there's a regional approach that DHS is working on with 2 people in the north, 2 people in the center, 2 people in the south and everything. And leaning into that as a short-term way of addressing these things and figuring out, maybe in the north, we could look at rural. In the center, we could look at urban. In the south, we could look at suburban or whatever approaches to things. But then also thinking about, is there a model that we would prefer for the whole state that might be something even more than that, but it's going to require more funding. It's going to require more planning. It's going to require standing up more facilities, getting more data and stuff like that. So as people are talking about these things and thinking about these things, there may be some things that are achievable that we want to make as short-term recommendations, but also try to help the state build a long-term vision for what we want things to look like 10, 20 years from now. And this is an opportunity to have that discussion. So thank you. And if I leave, thank you everybody for such a great discussion today.
Thanks, Brad. Okay, so I know I can't remember, Jen, can you remind me, is this where somebody else is jumping in to facilitate? I know that Danny's doing the last session. Danny, are you leading the open session part, or you want me to do this?
I think I think it's either I'm trying to find my slides here.
I haven't been looking.
I think it could be you or Brad or whomever for the open session.
Okay. Brad, do you want to take a lead? Okay, so I'm just gonna.
I said my
sorry,
piece. Thank
I
you.
meant Josh. I meant Josh, not Brad. I apologize. I'm looking at
Okay.
Josh, but I'm saying Brad.
Sorry, I did too. I just followed Jen's. But yeah, we were talking about you, Josh.
Hey, if I get compared to Brad, that's cool. I'll take it.
You guys are so similar now.
Well, no. Is there anybody, I guess, in the room with Natasha? I can't see anymore. I thought there was somebody there. And I see a hand raised.
Can you hear us in the room?
Can hear you.
All right, go ahead, introduce yourself and say
Sure.
whatever you'd like to.
My name's Karen Fries. I'm a clinical social worker and I work with Accent Care Fairview Home Care or Health Services. And I was asked to come here today on behalf of our group, just because this is a very interesting discussion. We're sort of on the opposite side of the wall from the hospital setting when it comes to dealing with these very complex issues. And we very often are sort of one of those community partners that are to be receiving these medically complex client referrals that are coming out of the hospital setting. And we see similar challenges, and we're just hoping that we can be part of this discussion about looking at solutions, because whether these clients and patients are currently in the hospital or if they're at home, we're seeing people that are at very high risk in the home setting as well. And what we experience sometimes is that individuals are being discharged from a hospital setting to home care, and they're really not, if there's not a safe caregiving plan in place, then they're really not an appropriate referral for home care. And then we're stuck in a situation with patients that are medically fragile, complex, and may not have a safe caregiving plan in place in the home. And our options for them are very limited. Part of that, I think, maybe is just an education piece about what can be offered through a home care setting, an official home care provider. Many people tell us, oh, our doctors told us that you would be out here the next day and that we would have, just like we had in the TCU or the hospital setting, we would have physical therapy and occupational therapy twice a day or every day. We're under really strict guidelines from the payer sources. Very often that's Medicare, and it's also medical assistance. We see people coming into their home being referred to home care that are refusing a TCU setting. Well, they were referred for TCU because they're probably not safe to be at home, and yet they're being discharged to home with home care orders. And our teams are strapped to know how to address the complexity if there's not an adequate caregiving plan in place. So our hope is that we're part of this discussion as home care providers as well. Because otherwise our options are very limited. If they're not safe at home, we have to do oftentimes a 911 call for a transport back to the hospital, to the ED, because they're not safe at home. And then we're following up having to make vulnerable adult reports as well. So I think that, the social workers and care coordinators in a hospital setting are going to be faced with some of the same challenges that we see in a home care setting. And it's not that we're trying to dump clients or patients back on the hospital. It's truly about if they're not safe at home, we honestly don't have a safe plan of care for them. They're at high risk. And, so I know that our group is hoping that we can be part of that discussion to figure out some of those solutions together. So that's one of the reasons I was asked to come today, is just to sort of get an idea of what is this council about? Is it appropriate to have our, like feedback from the Home Care Association, for example, as part of that, your discussion? And can we be part of that, brainstorming, problem solving metric that you're doing right now? And I don't know if this has been addressed in your group in other discussions or previous meetings, but that's why I'm here today on behalf of our particular home care agency. But I think that it applies to across the board for other home care agencies as well. One of the other challenges I can speak to as a social worker in home care is that when we see people coming home, you're talking about accessing those additional state or county provided services. One of the challenges that I routinely see is when I'm doing my assessment in the home, if that individual is eligible for medical assistance, disability, for elder waiver, alternative care waiver, CADI waivers, whatever, of course, I'm trying to assist them with getting connected to the counties to facilitate that referral. But we're also stymied by backlogs of those referrals. When I call Hennepin County to make a referral for a Min Choices assessment and an elder waiver, they're being told it might be 5 months before they get a call simply to schedule the Min Choices assessment, let alone to get on to a more supportive waiver program. So that's delaying the plan again in terms of getting appropriate support services in the home to help those people stay in the home safe. So we're facing some of those challenges on this end, out of the hospital setting. And we truly try and do whatever we can to prevent somebody from having to go back to the hospital. But sometimes it's really not feasible. I mean, that there's just not a safe care plan in the home for them. So thank you.
We appreciate that. I mean, and I think it goes exactly to what Natasha had commented on earlier in the discussion too, about how not everybody is going to be discharging or transitioning from the acute care setting to, a licensed facility, whether it's a SNF or somewhere else, that for many reasons, including maybe most importantly of which might be personal choice and preference, might be choosing to go home. So then what are some of those gaps or some of those areas that we can be wrapping around additional services for these folks that are choosing to go home for whatever that reason is, whether it's financial or personal preference or location or who knows what. But you and the home care providers and other community-based providers, I think, are absolutely a part of this discussion and are going to be a part of some of the recommendations and solutions to build out, because I think we said it too, that this is a full healthcare continuum thing. While the focus truly is on, getting folks out of acute care settings, which we defined earlier, and the population of which that we're going to be focused on, but it's going to take the whole continuum to really make sure that it opens up and flows and then keeps going and keeps working well and functional. So Laura, go ahead.
The clarifying question of your story, I apologize, I can't remember your name, but is it that when you're getting these referrals that the client is refusing a TCU setting, or is it that a TCU setting is not available, or both?
It may be that and my name is Karen. It may be that the individual or the family is refusing TCU setting. They're adamant about wanting to go back home. Otherwise, it may also just be that maybe TCU wasn't even suggested, but they're coming home and they're coming out of the hospital setting with very complex medical situations, and trying to manage those complex demands. You know, these are folks with multiple physical disabilities. Oftentimes they may have wounds. Sometimes they have wounds that they actually got while they were in the hospital or the TCU, and then they're coming to home. They may require catheters and catheter management and the risk of UTIs. So we're seeing folks, I think, that are coming out very medically complex. And whether or not they were offered a TCU, whether or not they refused a TCU, but if they're being sent home with only home care services in place and none of the other supporting programs and services, such as a waiver, you know, having a min choices assessment done while they're in the hospital as opposed to discharging to home. And then we have to refer from the community, and then we get told, I'm sorry, they won't be called for 5 months, you know, just to have the assessment scheduled. That's a huge gap and lag time in getting needed services to help them stay safe and to help stabilize their situation so that they can actually access the care services they need in the home, which very frequently need to go above and beyond what our home care services can offer under Medicare and Medicaid guidelines. We're not able to provide 24-hour care to them. We're not able to have a nurse in the home or a home health aide in the home for 6 hours a day. I mean, that's just not how our services are structured. And we know it, but we're trying to help them access additional services to meet that need. But there's a huge gap and a huge delay in being able to get those services in place. So when we go in the home and we find that they're not safe, we have very little option about how to help keep them safe other than to send them back to a hospital for stabilization and assessment.
If I'm hearing you correctly, your ask is that we have a more expedient and robust assessment procedure in hospital, and maybe improve patient education on what is and isn't actually feasible with home care services.
Those are two suggestions that would be helpful. But then also, if they are discharged to home, is there a way to expedite being able to get these folks additional support services via the county route, similar to what the hospitals are going to be asking for on their side of the wall? You know what I mean? The wall doesn't have to be a dividing wall. It really is when they need that acute care, they're in the hospital setting. But then let's figure out a way that we can smoothly transition them to home, but help ensure that they're going to be safe and meet their caregiving expectations when they are medically fragile.
Well, I appreciate all of that. And before Randy and Tiffany jump in here too, I just want to make sure, you know, so, and I don't mean to cut you off, but please do share these ideas and these solutions. And it could be, you know, at a future meeting like this, or it could also be, you know, having some of the home care providers, whether it's through the Home Care Association or others, share the ideas, thoughts, the barriers that are in place to that email address, the Transitions Advisory Council.dhs@state.mn.us, and send it in. And then what we're going to do with that information, any public comments that we do receive, we're going to, staff will then send them to all of us on council, and then be able to kind of incorporate them into the report. So everybody's voices can be heard and included in all of this work as well. And again, before I quickly go to Randy, Rachel, are we good on time? I don't know how long the last little bit was supposed to take here.
I think we only have a minute or so before we need to close. I mean, we've had such a great conversation, and I really appreciate the open session comments and agree with Josh. I think everything that gets written down is coming, is going to be part of the analysis within the report. And so it's really great to get everybody's feedback. We don't have a lot of time. So Randy, if you can kind of keep it short, we'll finish up and move to the close.
I just want to say thank you, Karen, for what she's explained is seriously trying to find home healthcare agencies right now. I have clients where I contact more than 10 agencies trying to secure someone to be able to get even physical therapy, occupational therapy. I'm calling lists and lists because providers don't have the capacity, and oftentimes hospitals don't even fully explain the care needs that are expected for them. And then when that caregiver, that's what she's kind of explained, let me know if I'm wrong, Karen, is then they get there and they're like, this is an absolutely unsafe discharge, and then they're right back in the hospital. And I just want to say that even PCAs, I have to tell clients, if you don't have a family or a friend who's able to become your PCA, there is no staff right now for anybody to receive at home. And so we want people to be in their home settings. But right now it is getting harder and harder for people to get home health nurse, physical therapy in home, or any other services within the house. It is absolutely crazy right now. That's all I have to say. Sorry.
Thank you. Okay, so we are at the end of the open session, but again, throughout this session, send email comments, add to the information that's going into the data that we're using to look for themes and major messages for recommendations. We have one more piece of the puzzle to look at, and I know, Danny, you are going to kind of run this part of the process. It's really just to kind of go through the report, which is that last section in the file that you all received. Danny, I'm just going to pull it up so people can remember it while you're having the conversation, because that'll, I think, be helpful for folks. Let's see here. So what we talk about is a general outline, and what we want to do is prepare for the next meeting. We didn't get a chance to look at this, Danny, so that might be one of the things that we want to put into our actions for the next meeting.
Okay. So where are we at, Rachel? I'm like lost on that.
I'm sorry. It's my fault. I have not done a good job of timekeeping at this meeting, but it's also because everybody's done such a great job sharing ideas, so I think it's all good. What we're doing is really looking at the report itself, which that's why I was saying, Danny, I didn't get a chance to show it to people yet because we did such a deep dive into the target population. But I think, Danny, what I wanted to kind of make sure that we had a conversation about is not so much the outline right now, but the target population, kind of circling back to the beginning of the meeting, because we have a really complex task. I mean, we've been mucking our way through all the details and thinking about it from these different levels of implementation. And so I think what we need to do is kind of pull back out and say, what are our next steps for the next meeting? Does that make sense to you, Danny?
Yes. Yeah. So, I mean, wow, what a great session we've had this meeting too. I just wanted to say thank you for everybody who spoke up. It was really, really awesome to hear everybody's thoughts on that too. So, I think, some of the things that came out of here too was that we were taking a lot of notes on your request for assessments and those kind of things. And we are going to be writing that up and putting it into some kind of a visual for the next meeting. I think that we're getting closer to looking at our target population for sure. But we're probably going to need to have a little bit more conversation about that at our next meeting too as well. I know that we talked a little bit about the assessment piece, which was what we were going to talk about here. Rachel, did you have anything else about that assessment piece that you wanted to say right now?
No, I appreciate what you just said, Danny, which is I think what we need to do is think about what we talked about today and think about actions that are going to take us further into the assessment process. And so I appreciate that you kind of brought it up that way, because I have taken notes as we went through the activities. I think like maybe what we do is, you know, kind of get that synthesized and back to you because it's your words. And then based on that, what we need to make a decision on fairly quickly is, you know, in the meeting too, we talked about the fact that we have some funds to do focus groups. So if we wanted to zero in on some of the topic areas we talked about today, we could set up some focus groups where we gather information from our partners, from people, and the open session is an example. But the problem is what Danny mentioned, which is the target population is still quite broad. And I think trying to figure out how to set up focus groups for gathering information is tricky. I think, you know, what I'm hearing from you all is that we need to do a gap analysis or some sort of formal assessment process to, you know, kind of keep going on this assessment so that we can get to a point where we're making recommendations. Does that make sense to the rest of the group? And I see Laura, your hand is up.
I think appreciating what you guys both just said, and then the talk back to I think like the data gathering that we had asked for. I'm wondering if we digest that data and then look at that piece and then like decide on like what a possible focus group might look like.
Mm-hmm.
Is that what you were saying as well?
Yeah, I think that's great, Laura. One of the things that's in our goals is that we also attend to possible disparities and challenges that are coming out of the services. And I don't think we've talked about that today. So that may be one of the things as well that we want to kind of make sure that we talk about, Laura.
So, with that, like you guys within the council know one of my other roles in my life is as a nurse at Children's Hospital. I know that entities have like healthcare diversity and equity teams. And I'm wondering if maybe that might be a good resource because they're charged with touching base with patients and getting their experience and making sure that they feel that their health care needs are being met like equitably, and they have good access and those types of things. So I wonder if they might have either like data that's relevant to that topic, or they might have like an idea of like specific outreach areas that we could look into.
I think that's really helpful. I mean, we have not talked about data with respect to that area. Was somebody going to say something? Yeah, I feel like I interrupted somebody. Sorry about that. That you know, my thought is that by the next meeting, if we can, like you said, Laura, review the data, we'll reach out and kind of gather information we have, get it to you in advance. One of the things, Natasha, you brought up in the past is the possibility of a state survey, but we didn't really have a focal point yet. So I feel like if we can get to a point in the next couple meetings where we zero in on exactly what kind of a survey could we collect that would build on the data that we already have and extend it, that could be a really good use of our time. Does that make sense to you, Natasha?
Yeah, absolutely.
Well, and kind of to what was just posted in the chat too. I mean, I think we don't need to recreate anything. We don't need to create massive surveys and reach out to and gather data. Data already exists. And so we gotta find that data, figure out what is relatable or what would make sense to pull in. And, you know, MDH probably has quite a bit of this as well. So what other agencies, organizations, and others have the data, so we don't need to be scrambling. We don't have time to you know, scrub everything and do
Well, and
everything we want.
I mean, I want to go back to our motions and just, I can't remember exactly what the motions were. Jen, can you read the two motions so that we kind of zero back in on Janelle saying that there are data that we might be able to access on socially vulnerable populations and that kind of information. So could you just read those real quick for me? Because I can't remember them.
I can. The first motion was that to ask Rachel or one of the facilitators to reach out to Susan Pleasance and secure data and transfer data into a visually understandable format. The second was for the facilitators to review literature and other data sources to identify original source data.
And then Janelle, you're saying that MDH has data, so would you be able to help us accessing that, or is that something that would come through Susan? How like
I can help bridge that. MDH has a whole division area that focuses on data collection for multiple facets and areas. So yeah, I can help bridge that.
Carol Backstrom obviously is our connection with MDH.
Oh, then great, she can do it.
Point person right there that can be that linchpin. Yeah,
that's great.
And then Natasha, you said we should reach out to Minnesota Hospital Association. I kind of got all of those confused together. Sorry about that. End of the meeting. So that's going to be another piece. I don't know. I don't want to mess with our current motions, but we'll just have actions to gather.
I think they're captured.
I think
it's, yeah.
Yeah, I think it captured under number 2. It was kind of, you know, yeah. And number 2 is other, you know, look for other data sources.
This is Janelle. I would also recommend us, I think DHS should be able to, or I know that counties can, in regards to data around economic assistance through the lens of the county. There are huge backlogs on application processing. And we have a huge, you know, there's a pretty significant issue on resource that needs to get figured out in DHS to be able to get that system to even function properly. So without that, there's no money for services. So for me, that's a pretty significant red flag. Because if we can get everything ready and rolling and running smoothly, we still have a funding issue. So I think getting some data around that to try to help support our economic assistance departments in all the counties in Minnesota would be very helpful.
Okay, great. That is fantastic. These are the kind of things I think Danny and I were hoping that we would get to.
Right.
I don't want to take the time at the end of the meeting because we're all tired, but do take a look at the table of contents. It was a first step and it was kind of before we mapped out the target population. So I think it's going to still be important to kind of really think about the outline and work on that as we proceed. So we'll take a look at that as an action and kind of reorganize based on the conversation today. So that hopefully it'll guide the next meeting and maybe we put more targeted time behind the outline so that we can really be clear about the, you know, assessment process.
Yeah, and I would just say, you know, maybe do that homework or whatever by by Friday the 8th. That, what is that? It's a week, maybe the 15th, and then that can give time for you, Rachel and Danny and others to kind of like look at it all and respond to it and factor it in so we can do the work, not just live as we're working. We can get it in, digest it, turn it into something, and then react to it.
And just to clarify, like the homework, like a quick bullet point, we have motion 1 and motion 2. And then anything else like that us as council members are supposed to do, just because I'm a little lost in the events.
I would just say read the outline and think about it given the conversation today. What we're going to try to do is get a new revised version, but the more we can, kind of really be thinking about it for the next meeting, we'll dig deeper into more of the structure and the details.
Right.
Well, with that, it is 3:30. So we will be adjourned. The next meeting will be April 30th at 9 a.m. Again, keep the comments coming, have them sent into the email address. Thank you, everybody, for your time and attention and ideas and everything else in the discussion. Has been fantastic. So I just want to thank everybody, and we will see you next time.
You guys are amazing.
Bye.